Thank you, Patty. Good morning. Oh, you all are still. Good morning.
Good morning.
I'm so very happy to be here with you today to speak about some things that you all will encounter in your careers as you become more advanced in your health professional life. What I want to do today is I don't want to just be a talking head. I'm going to introduce you to some concepts that actually will allow you to understand how certain individuals or many individuals within communities actually fare as it relates to health. I feel like I know some of you all here, especially that young lady right there, because she was at the Latino Health Summit this week that I was at and spoke very well about the program. So thank you. It was good. It's good to hear you talk about the program. And some of the things that was covered at the Latino Health Summit are things I'm going to talk about today. So I want to actually really kind of talk about, how many of you have heard of health disparities? Raise your hand. Okay, how about health inequities and health equity? So do you all really know the difference between those terms? Probably not, because they're also talked about interchangeably. I want to actually be able to help you not only understand the difference of those terms, but also to be able to visualize what causes those issues. And then as you all become future healthcare providers, some of you all are going to be working directly with patients. Some of you all are going to be running large corporations as they relate to health. And your success on being able to do any of your jobs is going to depend on the extent to which you'll be able to understand and address these issues. And so just kind of getting some definitions out the way. Here we have 3 definitions. Most times when you hear issues about health equity, people really are describing health disparities. Health disparities occur when you have the measurable differences between either the incidence, the number of new cases of a disease, prevalence, the existing cases of a disease, or health outcomes. They're only talking about the differences. They're not talking about what causes the differences. When we start talking about health disparities, it's when those differences in health outcomes or diseases are the result of systematic or unjust distribution of social determinants of health. What do we mean by social determinants? It's those things that we all need to be healthy. I don't care who you are or where you live. If you don't have access to good food, safe environments, safe housing, freedom of crime, freedom of discrimination, if you don't have those things in the right amount, any health that you thought you had, or any health status that you had, would clearly diminish over time. And I'll show you why. So health equity, what does that mean? It means no matter, think about the places that you live, and think about those areas that might be very affluent. And then I want you to think about those areas that may not be so well resourced. Sometimes we call them the hood, okay, or the other side, the proverbial other side of the tracks. In order for us to have health equity, for health equity to exist, it means that everybody in your community will have the same opportunity to have optimal health, and that nobody will be disadvantaged of having poor health because of where they live or who they are or where they come from. So I want to, this is a laser pointer here, may not be working. Okay, so I want to just show you, in this case, you have children looking at the baseball field. It's important for you to understand the difference between equity, equality, equity, and reality. So when we start talking about equality, it means that everybody gets a chance to go to the baseball field. But the fence is really preventing everyone from being able to see the game. In order for equity to occur, we would give every one of those children what they need to actually be able to enjoy the game. But the reality is that you have some people that actually able to have a bird's eye view, while then you have others they're in a ditch that will never ever be able to see the game. That's what some of these health issues are. How many of y'all have heard of Carter G. Woodson? Okay, so Dr. Woodson was a very famous person in the 1930s. He wrote this book called The Miseducation of the Negro. And in it, he talked about the way that's important in terms of understanding the way that we think. And I'm going to just say this quote because you will need it to follow this presentation. It says, when you control a man, in this case we're talking about today, a person's thinking, you don't have to worry about their actions. You don't have to tell them to stand there or go yonder. They will find their proper place and stay in it. You don't need to send them to the back door because they will go without being told. In fact, if there is no back door, they will cut one for their special benefit because their education makes it necessary. And the reason why I show this quote in relation to health inequities is because I submit that the way that some of us have been taught to think about health makes us, in a sense, not talk about the dream of health equity, but it really perpetuates a nightmare of poor health that you as healthcare providers or future healthcare professionals will have to grapple with on a day-to-day basis. Are you ready to change your thinking and challenge the thinking of others that actually perpetuates a nightmare of health inequity as opposed to the dream of health equity? So when we start talking about this whole issue of disparities, here is a graph from 1970 to 2010, and it looks at life expectancy by race. And in this case, it looks at white, black, and then all races. On the one hand, you'll see from 1970 to 2010, life expectancy is going up for everybody, which is a good thing, right? In this case, on the top, you have the white life expectancy rate, and here you have the black life expectancy rate. So even though that it's getting better for everybody, this difference between black and white is a problem. One of the things we have to understand is this phenomenon is real, but is unnatural. There is no reason, well, there are reasons, but there should be really no reason why you should have differences in life expectancy based on the fact that we live in the most resource-rich country in the world with the best health care. So why does this exist? And when we start talking about health equity and health inequities and social determinants of health and health disparities, sometimes we tend to think that it is only a problem of minorities, of racial and ethnic minorities. That is not the case. Now, you can't really have a conversation about health equity without really dealing with the health inequities or health disparities of racial and ethnic minorities. However, that's a minority health issue, which is part of this. But how many of you are from Appalachia? Okay, well, Appalachian region, we have a number of counties in Ohio. I think 1/3 of the counties in Ohio are considered to be Appalachia. They have some of the worst health outcomes that you would see anywhere else in the state, in terms of chronic diseases particularly, lack of access to health care. So when we talk about this issue in terms of health equity, while race is a very important component of it, it's not just about race. A lot of the individuals who reside in Appalachia are white, lower income, under-resourced. They have some of the worst health outcomes. So one of the things that I also want you to think about is, what do you all think, don't look at the screen real quick, what do you all think is the leading cause of death for everybody in Ohio? Yes, ma'am.
Is that heart disease?
Yeah, you see the slide? No, I know. You're absolutely right. Heart disease. Heart disease is number 1 by cancer, lower chronic disease, and then the 10th is septicemia. Things that as healthcare professionals you are going to actually be dealing with. But you can't really just look at the leading causes of death without thinking about the stages in terms of when individuals are going to encounter those diseases. Okay? So it's not just about that. So when you think about health and health inequities, it's not just about what's killing us, it's about at what point are we most likely to be able to see that. And by the way, when you start looking at these diseases and then different racial and ethnic groups, the causes seem to shift. Now, remember Dr. Woodson, he talked about controlling thinking, right? How many of you all believe that we have an opioid epidemic in this country? How would you know? How would you know? Anybody?
The news.
The news, what else? Have you all may even know or have family members or know of someone who was dealing with this. And so when we talk about the opioid epidemic, we're not just talking about prescription drugs, but this whole really bad problem of these synthetic opioids, fentanyl, carfentanil, that is so powerful that 1 grain, like a sugar grain of these synthetic drugs, can send you into overdose. I mean, it's terrible what's going on. But when we start thinking about it, we have to think about it in terms of incidence versus prevalence. So, in your perspective, in your mind, I want you to think about this issue we've been talking about, disparities. Is this whole issue of opioids a new issue, or is it something that we've always been dealing with? What do y'all think? Anybody? Yes, ma'am.
Something that we've already been dealing with.
And why do you say that? You're right, but why do you say that?
Because we've always had drug problems. Now they're just highlighting them increasing.
Okay, so what kind of drug problems have we always had that can you think about?
Like heroin.
Heroin? Anyone else? You're absolutely right. Anyone else?
Crack.
Crack, right? The reason I want to bring this up is because the president has talked about declaring a war on opioids. We actually have Newsweek and other magazines that talk about how bad of a problem this is. But in some cases, when you think about it, in some cases, minorities have felt that they've been drowning in this whole issue of substance use before there was ever an epidemic. So, think about this. In some cases, Black Americans, some of them believe that they have actually been whitewashed out of this new so-called opioid epidemic. And I want you to think about it this way. We have 2 images of people struggling with addiction. Who is most likely to be perceived as a sick person? And who's most likely to be perceived as a criminal? The reason I want to be able to show you this is because it's all about perception. It's all about the way you've been taught to think about these problems. Here's something else. How many of y'all believe that HIV/AIDS is a problem? Okay, so do you all know what AIDS was called when it first came out in the history? Yes, ma'am. GRID stands for Gay-Related Immune Deficiency. See, she spoke even well then, she's speaking well now. You're absolutely right. So, in the 1980s, we saw all these newspaper articles about this gay cancer that were killing people, right? But it's all a matter of perspective. Because if you were just thinking about HIV in the 1980s, you would think it was mainly a disease that impacted gay white males. But you look at it today, the majority of the folks, the women that have HIV or AIDS in this country are women of color. Men who have sex with men of color are the fastest growing group who have HIV or are acquiring HIV in this country. So when we start talking about HIV and we think about where we've been versus where we are now, who is most likely able or likely to get this disease, and what does that mean for you now in terms of what you're going to be dealing with as healthcare professionals? We have to change the way we think. As healthcare professionals, one of the things that you all are going to have to be dealing with, we talked about health disparities. How many of y'all have heard of healthcare disparities? Something that you're all going to deal with. Healthcare disparities is when you have maybe 2 individuals who come into a healthcare system or and what will happen is they will present with the same disease, have the same insurance, same resources, but they might get a different standard of care. Why is that? So now here's the other thing. For you all who are going to be providing direct patient care, one of the things you're going to find out is that none of you are going to be nurses or doctors or physical therapists or healthcare executives, and you're going to go to school and say, you know what? We're going to provide a different standard of care for people who have the same health conditions because of their race, ethnicity, or sexual orientation. Particularly, but this happens every day. It happens so much that there was a study about unequal treatment that talked about the extent to which it happens. And then every couple of years, there's a national healthcare quality disparities report that talks about the extent to which this happens. You all know better. You all are going to be trained in these issues. What will you do to address the whole issue of healthcare disparities? Now, we talked about thinking. It's important to actually have a root cause analysis. You have to be able to understand what is driving the problems that you will see, not only as healthcare professionals, but in the community. So can anybody tell me what this is? Anybody know what that is? Right here. Mold, right? Is it a good thing or bad thing? That's bad, right? So, can you tell me what kind of health issues are you most likely to experience if you lived in a situation like this? Asthma, right? Excellent. So, you walk in and you all see this. Now, you all are reasonable people. This is something, and in fact, if you haven't seen it, you will see this at some point in your career. What would you tell people to do to address that issue? How could you address this whole issue? This is mold in the basement. This is mold like in wood, so it's a bad roof. So, but what would you tell people to do to address this issue?
Hire somebody to clean it.
Hire somebody to clean it. That is a valid response. But that presupposes that you have money to do that. But you're right. What else could you do? Ma'am?
Tell them to get out of the house.
Tell them to get out the house. Move. Get out of that, right? And that will be a valid response. But it presupposes that you actually have resources in order to move. But that is an option. What else? Give me two more. I know you're chomping at the bit to tell me this. Somebody wants to say something, huh?
Help them clean it.
Help them clean it, right. How would you clean it? How'd you say it?
Bleach.
Good old bleach, right? 99-cent bleach, some soap, and elbow grease. And if you had that, you could, and that would be great. You could do that. One more. Ma'am.
Fix the problem with the water coming in.
There you go. It's the root cause analysis. So here's the thing. Everything that you all said would be a valid response. But we talked about root causes. So the bleach that this gentleman here said could actually fix the problem, but it wouldn't fix the source of the problem. So think about this. Let's say we took the example of bleach and we scrubbed it and got it together. But let's say that one of the folks or the people who lived in there suffered from asthma. If you fixed it with the bleach solution, which is a strategy, what would happen is that at some point, people who might be suffering or living with asthma will be coming back to your healthcare facility. And it's not because of the fact that you were participating in this whole healthcare disparities issue. It's not because you, as future nurses or physicians or physician assistants, didn't give the best quality care. It's because someone has failed to understand what was bringing that person in the first place. And so what does that mean for you all as future healthcare providers, even those of you all who are going to be running healthcare organizations? It means that if you didn't get to the root cause, the resources that you need or your budget might be blown because the same people are coming into your facility over and over and over again to address a problem or deal with the problem that was dealt with on the surface, but never the root causes. I want to bring that home because that is how we tend to deal with health disparities. So, does this come to mind? That's how usually healthcare providers deal with it, as opposed to dealing with the root causes. Now, I know I'm getting, so how do things get so bad? So, we start thinking about the disparities. Have things always been this bad versus how did they get so bad now? And the other thing is, when you think about the work that you're going to be doing, are we intentionally perpetuating these inequities? So, how many of you all heard of redlining? Show of hands. Can anybody tell me what it is? Hold on, without looking at that. Can anybody tell me what it is? Yes.
Is it where they divided off the communities into like the lower income or racial minority groups and they were treated less, or like they congregated all those people into that area where they lived because they like to provide, it was based off their income level and that to depend on like how much allocated resources they got from the community?
Almost. You're there. You're there. Anybody else? Okay, y'all gonna make me work. I say I'm gonna have to get really comfortable now. Okay. You're right. Anybody else? Just one more stab at it. Okay, so in the 1930s, after the Great Depression, as part of the New Deal legislation, we were trying to get people to work, and we were trying to make sure that we could stabilize home mortgages. So what the federal government did is they actually worked with a number of different people at the local level, realtors, business people, developers, and they came up with a way of trying to determine how could they actually back up home mortgages made to individuals. And so what they did is they came up with a system, and they actually would draw a map, and this is Cleveland, and they would rate neighborhoods based on a number of factors: the built environment, the age of the homes, but there was also a racist tint to this. They would actually determine the worthiness of those neighborhoods based on whether or not there were African Americans there, or whether or not they were immigrants, or even people religious or Jews. So check this out. This happened from the 1930s to the 1970s. The neighborhoods that you see, the racial segregation, or even the way that suburbs were built, just didn't happen. It was based on policy that advantaged certain groups and disadvantaged others. So how does that relate to the health problems that you will see? Redlining. And by the way, if you ever get a chance, there's this website called Mapping Inequality by Richmond University. And it actually allows you not only to see these maps, but it actually allows you to see the description. I've even seen instances in these descriptions of these neighborhoods and these restrictive covenants that says none of these properties should be rented to anybody who is black, Jewish, Armenian, or Italian, or anybody of the Semitic race. They actually have this in some of these covenants. Now, what does that mean? Well, there's a lot that we can go into, but not only does it mean how does it helps us understand how our neighborhoods were developed, but the way to even think about race, the way to even think about who's, for example, African American or more so white, has really only been in existence for like the last 70, 80 years. But what it does is it fundamentally changes the way that our neighborhoods have been looked at. Oh, by the way it got its name, this is Cuyahoga County. If an area was shaded in green, it was rated to be the best place for you to be able to live and to back a loan. If it was rated, shaded in blue, it meant that those areas were still desirable. If it was yellow, it meant that that area was declining. And if it was red, it was meant that it was hazardous. You don't want to actually make loans there. Now this happened all over the United States. And I'm going to show you how this relates to this area too. So think about this. So if you look at the areas that were deemed hazardous, and I actually draw a line around that, we can look at that and call that maybe the region of inequality or missed opportunity. Now, this is something that we've developed. This is called a health opportunity map. I'm going to show you what that means. But the way that you look at this is that any area that's shaded in blue actually means that the residents in those areas have the highest opportunity to have good health. Any area that was outlined in red means that the residents in the area have the lowest opportunity for health. But there is a gradient. Why is that important, and why do we talk about history in relation to health opportunity? Because the same areas that were redlined in the 1930s tend to be the same areas that have the worst opportunity in 2018. Y'all okay? Because y'all looking at me like a farmer looking, a cow looking at a farmer putting up a new fence. I'm like, where's he going with this? Okay, here we go. Chickens are coming home to roost. And what does that mean? Because all that stuff that happened back in the day are things that you're going to deal with as healthcare professionals. So, what do you all think influences health? Would you all think it's mostly clinical care, personal responsibility, social environment, or policy? What would you all think? Ma'am? Say more the environment, more so than anything else? Okay. How about any others? Yes, ma'am.
It seems like policy has kind of a limited involvement on that diagram, but I feel like that should be more, because even if you put forth more effort as an individual to try to be proactive in achieving better health status, there's still rules and things that are put in place that can limit what you have access to.
Okay. How about the table right there? I know you all want to say something. What do you all think?
I honestly think that they all should be equal.
They should all be equal? Okay.
Every part plays a big role in how
Okay. One more. How about back there? That table. Yeah, you lady who act like she don't want to say anything. Yes, you right there. What do you think? I'm going to pick on some folks. That's just who I am. So what do you think? Personal responsibility or maybe clinical care? Okay, the reason why I ask you all this is because there's no doubt that all of these factors actually influence health, but clinical care only really accounts for about 20% of really what constitutes health. Personal responsibility, and think about this, have you all heard of food deserts? Right? So if I tell you, you need to take responsibility for eating healthy and a well-balanced meal, but you live in a food desert, how much personal responsibility impacts health? The reason I want to be able to show you this, because anytime somebody tells you that we just need to take personal responsibility in order to address your health, and you haven't taken into account any of these other things, you are actually setting people up for poor health. And it means that the way that you're thinking about the issue is not the way that it needs to be thought about. So, what tools can you use to be able to think about this? Well, one of the things I talked about, we have something at the Ohio Department of Health we're going to be using called the Health Opportunity Index. And basically what it does is it takes all those social determinants of health and it actually looks at them at the census tract level. You might know why we use census tracts as opposed to zip codes. Anybody thought about that? Sometimes you'll see data and they'll have it by zip code. If that's the only way that you have your data, it's okay if that's the only thing you got. But remember this, zip codes are only used or designed for the efficient delivery of mail. Although they constitute a geography, they're not designed to be homogeneous. You can have two zip codes, one next to each other, adjacent to each other. One could have 10,000 people in it, the other could have 50,000 people. Census tracts are designed to be homogeneous. If you have a census tract, it's designed to have anywhere from 1,500 people to 8,000 with the optimal size of 4,000. You want to use census geographies because they're designed to be homogeneous. You can compare them. So what we do is we take all these social determinants and then we use a statistical method. Some of you all will be using this in your studies if you haven't already, called principal component analysis. It's a data reduction technique. So it takes all these social determinants of health and then put them together, and then it comes up with a single score, and it measures health opportunity. The reason why we use principal component analysis, because certain social determinants of health for Ohio tend to be grouped with one another. So if we say that we know that an area has low health opportunity, but it's an economic component, it means that jobs, segregation, and income inequality are the root causes what's driving that poor health opportunity. If I told you that it was the consumer component that was driving that, what it means that education, food access, and what they call material deprivation is driving the poor health that you see in that community. It's something that's been used in science for a while, but we're now using this in health. So this is Portage County, where we are now. The areas in blue are the areas in Portage County that has the highest opportunity for health. A score of 0.6365 means that you have the highest opportunity for health. However, a score of 0.3937 means that they have the lowest opportunity for health. This is Portage County. This is the Northeast Ohio Medical University. This is where we are. And I want you to see where you are relative to health opportunity. So, here's where we are right now. This area around the Robinson Memorial Hospital, Maple Grove, Cemetery, St. Prospect Street, those areas in Portage County have the lowest opportunity for health. So let's just look at these areas real quick. What do y'all think is causing health in this one part of Portage County? What do y'all think is driving poor health there? Any guess? Well, I'll say this. If you live in this census tract, you can expect to live to be, at least our calculations, to be 71 years old. If you live here, you can expect to be 77. But here, where you have more, higher health opportunity scores, 79. If you live over here, you can expect to live to be 82. But there is a lot more than that. Remember that I told you, in terms of the way this health opportunity index, if I say if it's a consumer issue, it means that education, food access, or material deprivation is causing health issues or driving health issues. If it's economic, it means income inequality, segregation, and job participation. When I did the analysis, I can tell you now that individuals who live in these two census tracts, what is driving the poor health opportunity, things that you're going to have to deal with if you were here, is this whole issue of material deprivation, lack of access, goods, and services. Down at the other, down here, at the other, and then this census tract is income inequality. Why is this important? Because if you try to go and look at health opportunity and you do your best medical work and you do things that you can to drive the diseases that are occurring in those communities, and you don't take into account this stuff that we're talking about, the things that you think will work in terms of your healthcare profession will be limited in scope. You have to understand what is driving the poor health of the people that you see. Now, this is Trumbull County. This is the same type of analysis, health opportunity index. I've actually been able to point out an area that has high opportunity, low health opportunity. But why is history? Remember I talked to you about that whole redlining issue? Well, believe it or not, this is a redlining map from 1930s of Warren County. Real close to here, right? So, you have all these, remember, what did the blue area stand for? Best areas, right? I'm sorry. Green is the best, right? Blue is what? Right. Yellow is? And red is? All right, so you're saying, okay, Chip, why are you bringing this up again? That happened in the 1930s. Man, stop living in the past. We're in 2018. Can you tell us how does that relate to what we're dealing with now? Well, first of all, this is the original redline map. Using today's technology, we can actually digitize this to understand where this is actually occurring on the street now. So, this is 1930s Warren. This is the health opportunity index for that same area. What I want to be able to show you is that the same areas that were declining are areas that have the worst health opportunity now in 2018. What are you planning on doing as future healthcare professionals to make sure that whatever you do takes into account these realities? So you can't really just think about health in terms of whether or not people are taking their personal responsibility. You have to think about past, present, and future, and the structures that guides exactly why people are healthy. So we thought about it was just personal responsibility. Well, we do have to take personal responsibility. But the question becomes, what is going on in your environment that actually dictates how much responsibility you can take? So as healthcare providers, why are you going to treat people with your best medical practices and then send them back into conditions that live like this? Okay, so here's the last thing I'm going to say because I'm running out of time. There are 3 communities, 3 neighborhoods in Cleveland that have the same pattern. In this census tract, they can live to be 63, and then half a mile, they live to be 81 and 82. How many of y'all see that as a problem? You could see that, but what's driving it? Using the tools that we talked about, I can tell you the income inequality, jobs, and segregation is causing that problem. Here is the census tracts and who's there. And then this, and the other thing I want to show you is that over here, the median age in this census tract is 62. The median income is $23,000. The median income in this census tract is 108, and the median income in that last one is 123,000. And we start talking about how much money is in the community. Don't ever let anyone think that income and resources don't matter. In this area that had, and then there are 3 neighborhoods next to one another. In this area that has the worst health opportunity, you have about $14 million annually floating around that community. Yes, sir?
Where exactly in Cuyahoga County is this?
This is near the Baldwin Purification Plant, right around Fair Hill, where there used to be an old Kaiser there. So this is around Fair Hill. This is Cleveland Heights around Mount Overlook, and then this is near Shaker Lakes, as a point of reference. So, and the reason I want to be able to say that in terms of, again, just whole income, $14 million in this neighborhood versus $90 million floating around versus $132 million. Income counts. Now, we've been talking all this stuff about health equity. Oh, by the way, the unemployment is 6.8, 4.3, and 3.2. The reason why I talk about employment, you all have lived in the last, 8 years through one of the worst economic crisis since the Great Depression, right? So, at the height of the depression, the recession, unemployment was, 8%. So I took this data from earlier this year. In this area, it's still 6%, even though that we're now in the midst of a recovery. Well, not everybody's recovering, but that has an impact on some of the things you see. Now you're saying, okay, Chip, you're telling me all this stuff. I'm a biochemistry major, I'm a biology major, I'm majoring in nursing, and this stuff has nothing to do with me. In fact, some of you might be thinking, all that stuff you've been talking about that redlining and the stuff that happened in the 30s, I wasn't there, didn't have anything to do with it, I don't want to hear anything more about it because I'm a great person and I'm not going to do any of that stuff. And you're right. However, the things that have happened and the things that still are happening are going to impact the way that you do your very jobs as a healthcare professional. The same areas that we were redlined, the same areas that are dealing with these issues are the same areas that they went after with those subprime loans. It's the same areas that you see a lot of these check cashing places. So there are a lot of still predatory issues going on that impact the very people that you're going to be serving. So, as we go through this, why am I saying all this? And what does it have to do with health equity? One of the things, if you ever hear somebody do a health equity talk, and they tell you all about disparities and inequities and social determinants, and they don't give you a vision of health equity, you have to ask them for one. Because when you talk about health equity, it's kind of like me requiring all of you to get an A in the class to draw an accurate picture of a Martian, even though you've never really seen one. So a lot of times we ask people to talk about health equity, and we do it by describing health inequity. So what does this mean? And how do I talk about health equity within those examples that I showed you? Remember I told you here is that in this case, life expectancy is 63, 81 and 82. I told you with the unemployment and the annual salary and what people are living. In order for us to have health equity in this area, we would have to do things to at least be able to increase the life expectancy from 63 to 81. The coronary heart disease as it currently is 16%. It means that 16% of the adults in this neighborhood have the #1 killer of everybody, coronary heart disease. In order for health equity to exist, we would not expect coronary heart disease to be more than 4.1%. Diabetes currently is 25%. It should not be any more than 8.1%. And cancer, it's 11%. In this neighborhood, it shouldn't be any more than 8.1 in stroke, no more than 4. Why is that? When health equity exists, it doesn't mean that people are not going to die. It doesn't mean that we're not going to have diseases and people are not going to be dying from heart disease or diabetes or cancer. What we're saying is that they're not going to be dying at these disproportionate rates. You would never have a situation where you have life expectancy with a 18-year difference. And by the way, don't let anyone think that just make you think that just because it exists that now life expectancy is 63, 81, and 82, that's just how things are. That is unnatural. Health disparities and health inequities are on a natural state of being. It is a human-made problem, and it means that humans can solve it. And if we really then to think, well, people in this neighborhood just tend to live to be 63, and that's just too bad, that's how it is, that is the wrong type of thinking that you have to challenge. So now that I hopefully have inspired you and not thoroughly depressed you with all this information, the question becomes, what is your role in all of this? Do you really believe that you, as individuals, as future professionals, can you really do something about it? The question is yes, but in order for you to begin to do something about it, you have to change the way that you think about this, and you have to challenge the incorrect thinking that other people have. By the way, I don't really kind of sugarcoat this because you all are in the academy and you are learning. I do the same presentation at medical schools, other medical schools. I do the same presentation at nursing schools, in front of doctors, in front of elected officials. Because part of the issue is that the way that some of them have been taught to think about these problems are incorrect. And the only way to be able to challenge incorrect thinking is with the truth, and you have to challenge people, because sometimes I'll go in, even though this is based on real data, and people sometimes think that I'm lying. They're like, man, it can't be that bad. I don't know where you're coming from, but this is not reality. And when I hear people talk like that, I just sit back and I try to figure out another way of actually getting them to the truth. Because sometimes the reality of what I'm talking about is so painful that people don't want to think about it, and they rather think that it's not happening, and they tend to want to stay within their little bubbles. But the reality is that's not how life works. So, what is your level of readiness as scholars in this great program to really confront this? Now, have you all heard of cultural competency? Right? How many of you all know about the difference between cultural competency and implicit bias? Can anybody tell me the difference? When you're culturally competent, it means that you have really learned and you have put yourself in a position to understand exactly how different groups of people really think about the world, what they like, what they don't like, what their experiences are. And so when you go into a doctor's office and you see an elderly man or a woman, if you know enough about their culture, you will probably be better off in terms of providing them services, because you are actually being able to understand something about them that allows you to communicate and interact with them better. But what happens if you might think that you know, for example, how to deal with Latinos, how to deal with African Americans or the Asian community, or in Columbus we have a very large Somali community. You might have some insights about their lifestyles to help you serve them better, but maybe you have some issues of implicit bias. So implicit bias means that there might be issues that you might have with groups or people, and even though that you are a good person, even though that you have this intense desire to help and serve, there are some things that are unconsciously going on in your mind that you don't know about that affects the way that you deal with individuals. So let's just say, for example, and by the way, they have this really cool site called the Implicit Bias Test at Harvard University. What it does is it's called Project Implicit. And what it does is it subjects you to a number of different groups and images, and it actually helps you to determine if you have an unconscious bias. So let's just say that for example, I'm the only man in my household. I have a wife and a daughter, but let's just say that and I think that I might be a good dad and I'm a good husband, but let's just say that I have some unconscious sexist views when it comes to women. And so so I might know exactly if I see a woman or young woman coming into a clinic and I'm a healthcare provider, I know enough not to call her, hey girl, when she's a woman, right? But let's just say that even though I'm competent in that manner, that there may be some things that I have against women that I am certainly unconscious, and it impacts the way that I interact with this woman in a way that limits me being able to provide that woman with the best services that I could render. And so even though that I'm a good guy and I have women in my life that I care about, when it comes to my professional interactions with them in a setting where I can certainly impact their lives, I'm doing something unconsciously that is not in the best interest of that woman. We all have biases. The question is, are we willing to confront them Are we really to find out what they are? That is what implicit bias is, and all of us need to have that training and ongoing training, including myself. Again, I talked a whole lot about social determinants, but I didn't actually talk a lot about medical stuff. That's because I'm not a healthcare professional. And it's more important for me as a person who has to deal with health equity issues from a variety of instances, from mental health to HIV to all these different things, that I have to be able to help you incorporate those things that are happening outside of the clinical setting that's going to impact how you do your business. So some of you are going to be rich. I hate to say it, but some of you are going to be really well off, okay? And some of you are going to be comfortable, and some of you are going to be running big institutions. The question becomes, will you take what you understand and what you know to be able to promote health equity? Or would you fall into the trap that so many people do and ignore some of the things that we've talked about? And even though that you're there and you're highly educated and you're highly skilled, the way that you do your work is perpetuating the extent to which people have lower life expectancy, more disease than they should. There are things that we're doing to perpetuate this. What side will you be on? Here's the last thing I'll tell you. You're going to have infant mortality, heart disease, chronic disease, the opioid epidemic, substance use, homicide, HIV. All these things are going on, and they're going on simultaneously. And I say that because the opioid epidemic is something that we're focusing on, but all these other things are still happening. We're not going to actually solve this by working in silos. We have to also work together. So, you know what my first job out of public health school was? It was a disease intervention specialist. Y'all know what that is? So imagine this. You all are leaving a really good presentation, or bad presentation, I don't know. You know what you think of it. You are leaving this presentation, you go home and you know, it's been a long day, you had stuff to do, and all of a sudden you hear this. You go to the door, you don't want to be bothered, you're not expecting anybody, and then you see me. And like, man, what are you doing here? I said, well, I'm here to contact you because somebody that you had sex with, somebody came into our clinic with a sexually transmitted infection, and they named you as a sex partner. And I need to get you into the clinic before you develop advanced stages of disease. Now you sitting here like, okay, this is a joke. Who put you up to this? I don't know you. I'll show you my health department ID. It's all legit. And the reason why I tell you all that is because my first job out of public health school, I used to be what they call an STD investigator. And one of the things that I did is I had to go all over Cleveland, a city that I thought I knew, and had to find people with sexually transmitted diseases. And I had to bring them into the clinic. Sometimes when I would go and I would make those investigations, people didn't believe me. Like this one woman, she was contacted chlamydia. And I called her and I said, listen, you went to the doctor, they did a screen test, your test came back for chlamydia, I need you to come in. And she was like, you're lying, I don't believe you. And it's like, you're gonna pay me now, you're gonna pay me later. Then, sure enough, she developed PID, you know what that is? Pelvic inflammatory disease. And the reason why I tell that story is because there were so many people used to come into the clinic, and when I would tell them, look, what's going on? You need to take personal responsibility for yourself and stop having all this unprotected sex. And you know what? Even though that I was an STD investigator and I was trying to get them to deal with their HIV or their chlamydia or gonorrhea, they were saying to me, dude, I know you got this job, and I know you think you're important, but I can tell, you know, the way that I got this chlamydia or PID, because I was trying to survive. Some people were in relationships they had extramarital affairs, or some people were addicted to crack. Everybody came into the STD clinic through a whole different avenue. But I need to tell you that the very thing that they were most concerned about was not about the infection that I was concerned about. They had other issues that were driving them that were more important. And I used to go into suburbs, I used to go into crack houses, I used to go into a number of different places. And the one very thing that that whole situation taught me is that the way that by that time I had my master's in public health, and the way that I thought about health and what I thought needed to happen to keep people healthy was much more different than what the reality in the street was. So I'm not saying that my public health training wasn't good, but there was a reality about what governs health that made me really think about why I'm doing the work today. And so as I leave you, I'm saying that I'm so really honored to be a part of at least your orientation. I heard one of your members speak at the Latino Health Summit and was really impressed. And I really believe that you all are the answers to the problems that we have in terms of health inequities. But I have to warn you, is that the things that you are going to encounter, all the stuff that I talked about, you will see in your practice. Will you be ready? Will you adjust your thinking to do things that will get people more towards health equity and have them understand and achieve the dream of health equity? Or will your incorrect thinking be able to perpetuate the nightmare? The choice is really yours if you learn. Thank you so much for listening. I don't know if I have any time for questions.
We have time for maybe 3 questions, if anybody would like to ask a question before Chip leaves.
I gotta leave? No, I'm just kidding. No, and here's the thing. I talked a lot of stuff, and it's going to probably take you a couple of days to digest a lot of it, but I do want at least one question. Yes, sir.
So you're from the Ohio Department of Health. Do you guys work with the Ohio Department of Education then, since most of those health disparities relate to education disparities also? Or do you guys, it's like 2 different completely?
No, we are 2 different agencies, but we do work together with the Ohio Department of Education because they also realize that there are certain things that that they are dealing with in the schools that set people up, you know, for health inequities. So we do work with them very closely. Have you ever heard of, and one of the things that they are actually helping to focus on is this whole issue of ACEs. Have you ever heard of ACEs? Adverse Child Experiences. So there are things that happen, and the education, Department of Education is really good, but there are certain things that happen in childhood, bad things, sexual abuse, just all kind of traumas that happen with children that actually set them up for chronic diseases later on in life, things that you all have to deal with. And so the Department of Education has been really good at being able to help a number of different folks, not only in state government, but in the communities and schools, understand how we have to really watch young children, really between the ages of 1 to 5, because they realize that there are certain things that happen between ages 1 to 5 that set up the trajectory for their whole health status. And so that agency has been really good at promoting us. So yes, we do work with them. And that is one example that we use. One more? Yes, sir.
So if you're pretty much talking about that a lot of history, policy, all this stuff are connected to health. So are you pretty much implying that in order to get to the root of the problem, as doctors, it requires us working a lot more with like government officials in schools, you know, making policies and all that to really solve the problem rather than just in the hospital setting?
Yes, sir, that's exactly what I'm saying. You all are a big piece of the answer. There are a lot of people who don't necessarily understand the health issues that you see, but the health issues that you see have their roots in terms of the social context in which people live. And so in order for you to be the best health care provider possible, You have to be able to understand these issues. Otherwise, with all your years of training and knowledge, the impact of what you will have will not be as great as it could because you have not incorporated that into your practice. Yes, sir. Yes, sir.
Last question.
Okay.
Just going then off his question, what should a doctor's role be defined as then? Should it just be solely providing health care? Because, you know, you go to medical school to learn, you know, to practice medicine. Where should that line be drawn of, you know, do I go to help that person in their home? Or, you understand what I'm saying?
Yes.
So where should that line be drawn?
So in other words, you're saying, well, do you really have to make a house call to be effective? Or do you, or maybe as a doctor, should you be concerned with trying to solve the issue of poverty, right? And the question is that, first of all, you have to be aware of how your patient pool, you know, what are their living conditions, what's really driving some of the health issues that you see in your office. In terms of how to be involved, there are a number of ways you can do it in terms of groups, coalitions. So the question, I think that the way to answer your question sufficiently is to say that it's not your job as healthcare providers or future healthcare providers to solve decades or century-old problems. But you can be working with a number of different groups and organizations who have the wherewithal to directly address those social determinants, but they need your insight as a physician to be able to understand what may work and what may not work. And so you definitely have a role to play, and sometimes in terms of your role, it's just about being involved, staying up with this information on social determinants, being involved in groups, but also lending your expertise. But don't think that you as a healthcare provider have to solve these problems. Work in groups who are working together to address these problems. But I'm glad you asked it, because that is the question that is on everyone's mind, but no one ever verbalizes it. So thank you. Thank you again for everything.